Goni, or just range of motion, there's a couple of different methods that we're gonna show you for the various lumbar movements. For thoracolumbar flexion, we're gonna show you a tape measure method, and we'll also show you fingertips to floor where you're measuring where their hands are distance-wise. But for the tape measure motion or version, you're gonna have to make marks on the person's back. You're gonna find T1, kind of like how we did C7, C6 last term. You're gonna use that same method, find T1, make a mark, and then S2, like we just showed you today, make a mark. And then take an initial measurement, have them move, and then take a secondary measurement. Questions about that? So I'm gonna have you come stand here first. Can you either hold your hair out to the side or make it fun? Very sorry. So how do I find C6, C7?
Head flexion.
It wasn't that long ago. I could start at the base of the occiput and count my way down until I find the big prominences.
The one down.
And then one down. If I put my finger on two various spinous processes, what should move, what should not move?
C6 should move, C7 stays.
Should move. And remember, it's just gentle movements where this should move away, should come into my finger. Feeling C6, C7. I'm going to keep that bottom finger on C7, move down just one more, and then I should be on T1. Okay?
Yeah. So C6 should be the one moving?
C6 should be the one moving. C7 does not move. And then I'm going to palpate one more spinous process down, make my mark at T1. One thing, I think there's a couple, did anyone watch the Dr. Leva video on the quick, did she say C7 or T1? Does anyone?
She said T1.
She said T1, okay. I think some of the other resources might say C7 or there's some other options. It doesn't actually matter as long as you're consistent, right? Because what you're doing is you're taking the difference between your starting measurement and your ending measurement. So if you start at T1, you need to take your secondary measurement from T1, right? Questions about that? Okay, so then after I found T1, I'm gonna have my patient lie prone for me, please. And I'm gonna find S2. Can anyone please tell me? Ooh, I'm marking all over the. Don't do that. Can you hold that for me for a second? Thank you, patient. Who can tell me how I'm gonna find S2? I'm gonna find PSIS and then do what?
Move
Am
medially.
I gonna move directly medially from PSIS? Yes. I'm gonna find the inferior aspect of PSIS and then move medially from there, okay? So, iliac crest really seems to be, or at least for me, it's a really easy, yeah. Oh, sorry, hold on. I did just show you this. Okay. So iliac crest is going to be a starting point for a lot of these things, even when we get to side lying and anterior palpation. So iliac crest, where my thumbs hit, should be PSIS. I'm feeling PSIS. I'm going to move inferiorly till I find that inferior angle, inferior aspect of the PSIS. And then medially from there, I find a spinous process, and that should be my S2. So that's where I'm going to put my second mark. Everyone good on that?
So on the practical, if we get this as a Goni, will we lose points if we're like slightly off from S2? Like, will you like check like how you check like a palpation, if that makes sense?
Yes. We're gonna check. Because S2, I mean, that's actually a fairly simple palpation, I would say. You should be able to easily find those various landmarks. Okay, so I have my two landmarks. I'm gonna have my patient stand back up. I would keep them draped. Oh, sorry. Let me work harder. Here, hold on. Okay, so I'm keeping my patient draped. This is part of the draping, part of the rubric. Thank you very much. Can't think of words right now. So then I'm going to start, and we're going to use centimeters. I'm going to take my initial measurement from T1 to S2, and I'm getting 45 centimeters is my starting, well, 44.5 centimeters is my starting measurement, 44.5 centimeters. I'm gonna remember that number, and then I'm gonna stabilize my patient at their pelvis. You can either do it kneeling or standing, it kind of depends on patient height, obviously. And what you're gonna have your patient do is more of a segmental movement, so you're gonna tell them tuck your chin down, roll your shoulders forward, hands forward like you're trying to touch the ground. What you're trying to prevent is anterior pelvic tilt. There's gonna be some translation of the pelvis, that's just how you make sure you don't fall forward. So you're gonna feel some of that posterior translation of the pelvis. That's not what we're trying to stop. You're stopping when the pelvis actually starts to anteriorly tilt. Does that make sense? Okay. So stabilizing here. And you can also keep your thumbs on the PSIs here to make sure that can be another visual guide to make sure that your thumbs aren't coming up. So patient, I'm gonna have you keep your hands together and slowly you're gonna roll forward, roll your chin forward, roll your shoulders forward, coming forward. Good, keep going, go, 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 and stop there. To me, that looked like she had about 6 centimeters of movement. I'm gonna, wait, don't move. I'm gonna take one hand off, slight overpressure, any pain or symptoms there? Good. And then I'm gonna have her come back up. So I said, I estimated that to be about a 6 centimeter difference. I was at 42.5, so you can, this is the one time we're gonna let you over stretch the measuring tool, whatever you wanna call it. So from 42.5 to 48.5, that's your preset. You're just knowing what numbers you're starting and ending with. So I'll get it back there. Okay, same thing, roll your chin down, roll your shoulders down, go, 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 go. And keep going a little bit more, stop there. Any pain? Nope. So then that's where you remeasure. And I was way off. She's at 55.5 and I said she was at 48.5. So from 42.5 to 55.5, we're at 13. That's a lot of mental math for Sunday morning. 13 centimeter difference. Normal's 10. Questions about that?
Is there a reason why we estimate prior to actually taking the measurement? Why don't we just go straight to measuring?
Just a preset. It's part of the rubric. Yes, in the clinic, I'm probably gonna have my tape measure out further already, and I would just grab it and measure it, but it's part of your rubric. We want you to know the steps so that you're really good at the basics, so that when you get to the clinic, you're a rock star. Anything to add to that?
What I am.
Yeah, I mean, I would totally agree with Dr. Leonard. Clinically, I'm not really ever measuring this. A lot of like patients that I'm concerned about what their motion is in their spine, they're super symptomatic, so I'm not gonna want them hanging out here. So these are the skills we are required to teach, but I more so, when I'm looking at like range of motion of the spine, I am looking at finding hinge points, I'm looking at what I'm visually actually seeing in their movement, as opposed to taking these measurements. There are plenty of clinicians who do take these measurements, so you do need to know how to do them. I had to learn how to do them, but clinically, I would say I don't use this technique very frequently.
What if they have like scoliosis and stuff?
You would still be measuring the same thing, there's just anatomical variations between your measuring points.
It would be long.
What's that?
But you're taking a starting measurement and an ending measurement. That part's not gonna change. Two things I was gonna note is one, as you get through PT school, as you get through your clinicals, as you get into practice, you get much better at visually estimating whether it's like a Goni, hip flexion, it looks to be about 100 degrees to me, so you don't really need to preset your Goni if you are better at the visual and you just get that with time. And then also, what was pointed out to me is my initial measurement was 44.5, and I was saying 42. You were allowed to write down those numbers during the practical, or we'll help you remember the numbers if need be. We get it, it's nervousness, so.
We're more concerned about the performance of the skill than your ability to perform, albeit simple math under pressure.
Are the end feels for thoracolumbar and lumbar firm for all of them?
Firm end feels, yep.
Okay.
So you're getting that overpressure firm end feel.
And then do you do overpressure on the second rep as well? Or we should do
Yep,
over?
just the first one. Overpressures on the first rep. You establish your end feel on the first rep.
What's the end feel?
Firm. Sorry.